All right, let's do this. Welcome to the ED. You're on shift with me, and we are diving headfirst into some pretty high-stakes cardiology. These are the exact kind of cases that walk through the door, the ones where every single second and every decision you make really, really counts. Let's see how you do.
Okay, your first patient is in Bay 1. The paramedics just handed over, so let's dive in. The clock's already ticking. First up, we've got the most common, and honestly, often the most confusing presentation: chest pain. It can be anything, right? From a simple muscle strain to a life-threatening emergency. Your job is to cut through all that noise and find the real signal.
So, here are the details. 60-year-old man, sudden tearing chest pain. And here's the key clue, the real kicker from his story. It's radiating straight through to his back. That one specific detail should have alarm bells just screaming in your head. We're getting a stat chest x-ray, now. And there it is on the film, a widened mediastinum. You see that? The space in the middle of his chest, it just looks abnormally large. So with that history and that finding, what diagnosis just jumped right to the top of your list? Think fast.
That's exactly right. Aortic dissection. Now, what's really interesting here is just how overwhelmingly the evidence stacks up. That combination of sudden chest pain radiating to the back and a widened mediastinum makes this the #1 probability, by a long shot. Our next step is a CT angiogram to confirm, but we are already mobilizing the surgical teams. Great spot. Let's move to the next bay.
Okay, your second patient is a 43-year-old woman. Her pain's different. She says it's sharp, right in the center, and it gets way worse when she coughs or lies flat. But, and this is key, she tells you it feels a bit better when she sits up and leans forward. This is a classic, textbook history. This story is just screaming acute pericarditis. That positional nature of the pain, worse lying down, better leaning forward, that is the absolute hallmark symptom of an inflamed pericardium. But now the ECG becomes crucial, because we got to differentiate this from something much more sinister.
The crucial point here, what this all comes down to, is pattern recognition. In pericarditis, you see this widespread concave or saddle-shaped ST elevation all over the place across many leads. In contrast, a heart attack, a STEMI, that shows ST elevation localized to a specific territory, right where a blocked artery is. You'll also often see what we call reciprocal changes, ST depression, in the leads looking at the opposite wall of the heart. Spotting that difference, that is a core skill.
Okay, last chest pain case, we've got a 39-year-old smoker with central chest pain. You get an ECG. Now, at first glance, you might think, oh, NSTEMI, because you see ST depression. But look closely at where it is, leads V1, V2, and V3. This specific pattern is a huge trap for the unwary.
So I'm telling you right now, this is a STEMI in disguise. The standard leads are basically showing you a mirror image of what's actually going on. What part of the heart is infarcting here? It's a posterior STEMI. That ST depression in the anterior leads, V1 to V3, represents reciprocal changes from ST elevation that's happening on the back wall of the heart. If you were to do a posterior ECG with leads V7 to V9, boom, you'd see the elevation. This is an absolutely critical diagnosis to make because this patient needs the cath lab just as urgently as any other STEMI. All right, really good work on the chest pains. Let's switch gears and move to our next set of cases, patients presenting with syncope or a collapse. The cause could be totally benign, or it could be a sign of a lethal cardiac arrhythmia. First up, a 30-year-old woman who fainted on a packed morning commute train. She'd been standing for a long time, felt hot, then lightheaded, and the next thing she knew, she woke up on the floor. Her observations here in the ED are completely normal. The context, the story, it's everything here. This is just a classic uncomplicated faint, or what we call vasovagal syncope. The diagnosis is clinical, and you can remember it with the 3 Ps. You've got posture, prolonged standing, provoking factors like a hot, crowded train, and prodromal symptoms. She felt it coming on. When you've got all 3 and the exam is totally normal, you can be very, very confident in this diagnosis. Now, for a completely different kind of collapse, we've got a 76-year-old man. Paramedics bring him in, he's pale, and his heart rate is only 30. You immediately get an ECG, and that pattern is just unmistakable. The P waves, the atrial contractions, are just marching along at their own rate, completely divorced from the QRS complexes, which are the ventricular contractions.
This right here is the definition of a cardiac emergency. The electrical connection between the top and bottom chambers of the heart is completely severed. This is complete AV block, or third-degree heart block. This patient is at an extremely high risk of cardiac arrest and needs immediate pacing.
Excellent work. Okay, final section of the shift. This is where we put it all together. We're going to use clinical decision rules and our knowledge of treatments to make the right call for these patients.
Okay, your next patient is a 64-year-old woman who has new atrial fibrillation. You feel her pulse, it's irregularly irregular. So we need to assess her risk of stroke using the CH2DS2-VSC score. We factor in her age, her hypertension, her sex, and her score comes out to 3. So the crucial question is, what do we do with that score? At what number do the guidelines recommend we start a patient on anticoagulation to prevent a stroke? This is a number you absolutely have to know off the top of your head.
The answer is 2. The guidelines recommend starting anticoagulation for a score of 2 or more in men and 3 or more in women, which, is a bit of a separate debate. But our patient with a score of 3 definitely qualifies. This simple little score is such a powerful tool for preventing absolutely devastating strokes.
Finally, let's talk about the patient with a really fast heart rate who is actively deteriorating in front of you. How do you know when to stop messing around with drugs and start delivering a shock? You look for these adverse features. Are they in shock with a low blood pressure? Have they passed out or are they confused? Are they showing signs of heart failure like pulmonary edema or active ischemia with chest pain? If the answer to any of those is yes, that patient is unstable. They need immediate synchronized cardioversion, no delay.
And that's the end of the shift. Well done. That was intense, but you handled it. Before you go home, let's just quickly debrief and lock in the most important learning points from these cases. So here are the big takeaways. That pain radiating to the back should always make you think of dissection. That positional pleuritic pain, classic for pericarditis. Never, ever forget that ST depression in V1 to V3 could be a posterior STEMI. An extreme bradycardia causing a collapse is often complete heart block until proven otherwise. And finally, always, always assess for those adverse features in any patient with a tachyarrhythmia. You've seen a lot today. You've differentiated really dangerous chest pains, you've decoded collapses, and you've made some critical treatment decisions. So as you sign out, just take a moment. What's the one pearl, the one clinical clue that you're going to carry with you into your very next shift?